like to invite Professor Sujit Kar to give his talk. Professor Kar is professor at the King George University. He's one of the most active publisher from India. He has been cited thousands of times, and he has been very active in suicide research. And his other big issue is neuromodulation. And he is chair or co-chair of the Global Psychiatric Association, and this is one of the reasons we collaborate. And he's also editor of Global Psychiatry Archives, and if you want to publish, you're very welcome. So I'm very excited to have his expertise and listen to his talk, and thanks Sujit for organizing this meeting and giving this talk now. Thank you.
Thank you, Professor Renner, for the kind introduction. Thank you, everyone. So by this time, we are familiar about what is tDCS, how it operates. Now, in my presentation, I will be talking about the practical aspects of using tDCS in various psychiatric conditions and neurological conditions. So I hope my slide is visible. Can anyone online participant confirm whether my slides are
it's
visible?
visible. It's visible,
Are they
but I will do a slideshow, and then the picture is bigger.
I'm re-sharing it again. I hope it is visible now, and the slides are moving.
It's moving.
Is it moving?
Yes.
You are able to see the title slide now?
It's fine.
I'm moving to the third slide, fourth slide. Is it visible?
Yes, it's visible.
Okay. So, rightly pointed by Dr. Mohita that recently US FDA has approved tDCS home-based device for management of major depressive disorder. The important key point here is it is not only add-on treatment. FDA has also approved the use of home-based tDCS as a monotherapy. Those individuals who are not taking antidepressant treatment, they can be provided with home-based tDCS alone. So it is given for monotherapy as well as a augmenting treatment to the ongoing antidepressant treatment, and it is recommended for the adult population, those individuals with age more than 18 years. We can give it to 18 to 75 years. In that population, it was basically studied. So the FDA approval is having approval for a particular protocol, 30-minute protocol using the particular device, that is flow headset device, around 20 to 30 sessions as a add-on treatment to ongoing antidepressant treatment or as a monotherapy in patient diagnosed with major depressive disorder. So these are the specifications for approval. So one should not take this approval as a blanket approval for other devices, other electrode designs, and so. So usually when we are talking about neuromodulation, it is given approval for a particular coil or particular electrode of a particular device for a particular protocol. So it is very specific. So this approval we received in December 8th, 2025. It is based on a landmark study that is by Udham et al. It's a phase 2 randomized sham control trial involving more than 100 participants, a 10-week long intervention. So this trial was published in 2024 as a head of print, then subsequently published in 2025 October, and December FDA has approved the protocol. We all know that this has been already been discussed, that acute effect of tDCS is mediated through either depolarization or hyperpolarization. Underlying cortical area below the anode, they get depolarized, so they produce a excitatory effect. The underlying cortical area below the cathode, they get hyperpolarized, so they produce a inhibitory effect. This is the acute effect. Usually the acute effect lasts for few minutes, somewhere around 30 to 45 minutes. After 30 to 45 minutes, the acute effect goes. But there are some evidences that support that the acute effect may last as long as 24 hours. But that may not be that clinically relevant. So this will answer to some of the questions that are being raised during the first and second presentation. Whether suppose somebody is going for an interview or for an examination, whether before that tDCS can help theoretically. My slides are moving. I just want to confirm because some of the people they objected that it's not moving. And I'm sharing it again. Is it visible now? So acute effect in a therapeutic level lasts for around 30 to 45 minutes. Suppose somebody is receiving tDCS nearly 32 and the interview is scheduled after 30 minutes or 45 minutes, maybe it can be beneficial. How it can be beneficial? Like particularly DLPFC stimulation produces improvement in some of the basic cognitive parameters like attention, concentration, processing speed. So it may produce some therapeutic benefit theoretically. Practically, another thing is DLPFC stimulation is also having a mood elevating effect, reducing the anxiety. So may be beneficial for the anxiety and worry, apprehension, cognitive distortion, negative cognitions, those kind of things. But that effect is short lasting. Suppose your interview is after 2 hours, 3 hours, you may not get that benefit. So you cannot predict how long the interview will go and when your term will come. So maybe placebo effect you can get, but theoretically that long effect will not last. When you repeatedly administer tDCS, what happens? There is neuroplastic changes in the brain, synaptoplasticity, long-term potentiation, long-term depression, all those either strengthen a particular circuit or weaken a particular circuit. We target particular circuits during neuromodulation by using tDCS. Those circuits, pathological circuits, either they are hyperfunctional or hypofunctional, we need to regulate that. So that neuroplastic effect, when you repeatedly administer tDCS or TMS, both the things, tDCS and TMS, long run, they produces long-term potentiation and depression, producing a neuroplastic effect. And how long that effect will last? For both tDCS studies and TMS studies, it has been found that if you give for more than 10 sessions, at least 10 to 20 sessions, the after effect may last around 8 to 12 weeks. This is an average. There are individuals who report worsening of the symptoms immediately within few days of discontinuation of tDCS and TMS. And there are individuals who are maintained well even after months of discontinuation of the session of tDCS. So individual variations are there, but on an average, the after effect lasts for 8 to 12 weeks. So one need to be watchful here. This is what is the practical utility of this understanding. One need to be watchful for the initial 2 to 3 months of the follow. if you see that the patient's symptoms are again relapsing, again the symptoms are coming back, one may consider maintenance tDCS. If you see that the symptoms are maintained well on that same medication, probably you can continue on the same ongoing pharmacotherapy, remaining watchful for the subsequent follow-up visits. Once there is a deterioration of the symptoms, one may reconsider starting the maintenance tDCS. There is no clear-cut guideline that recommends how frequently one should give tDCS as a maintenance therapy. So one need to be it is a more of a decision of the clinician to whether to consider tDCS as a maintenance therapy, when to consider, at what frequency to consider. So I will be talking about that in the later part of my presentation. Say interesting image that say that the amount of electric current that we deliver in electroconvulsive therapy is 800 to 900 milliampere. The amount of electric current that we use in tDCS is somewhere ranging from 0.5 to 4 milliampere, but for a therapeutic purpose, mostly 0.5 to 3 milliampere. Commonly used is 2 milliampere. So 400 times less amount of electric current is being used. So suppose mostly people give electroconvulsive therapy almost at the threshold or supra threshold if you are going for a bitemporal or bifrontal ECT. If you are going for a right unilateral ECT, then you go for a 6 times the threshold, 5 to 6 times the threshold. But we are giving electric current for tDCS at a electric strength of 2 milliampere. It means that it is nearly 400 times less than the threshold. So there were some questions in the past, and people usually ask, do we need to estimate the threshold of the neurons to give tDCS? Just like in ACT, we calculate the threshold. In TMS, we calculate the resting motor threshold. But do we need to measure something in tDCS as well before giving tDCS? Unfortunately, for threshold estimation, practically there is no technique is being used before giving tDCS. Neither we estimate the seizure threshold nor we estimate the resting motor threshold, because we don't have anything to do with supra-threshold or sub-threshold. We need to fix to a particular, for all practical purposes, we are using a sub-threshold, a very significantly lower sub-threshold electrical stimulus for the modulation of the neurons. May it be 400 times less, may it be 420 times less, may it be 350 times less, but hardly matters, but it is a significantly sub-threshold amount of electric current is being used. There are many factors that determine the after effect of tDCS. Rightly pointed out by Dr. Mohita that the duration of stimulation is important. People tried with a lot of experimentation. They tried giving electrical stimulation. My slides are visible. Anybody is asking anything? So duration of stimulation, people tried with experimenting with the duration. Beyond 40 minutes, there is no additional therapeutic benefit. Whatever things that you will get, that is more of a side effect. If you go less than 5 minutes, 10 minutes, then there is practically no benefit. So most of the protocols, they centered around somewhere around 15 minutes to 30 minutes. In some special situation, people went up to 40 minutes. Intensity of electric current again ranging from below 0.5 or at 0.5 milliampere electric strength. Practically, the neuromodulation that is happening, it's not going to translate into a clinical improvement. So 0.5 and below, it is clinically insignificant. When you go beyond 0.5 till 3 milliampere, there is a range of spectrum of change in the clinical symptoms. Beyond 4 milliampere, you are likely to get more side effect, no additional therapeutic benefit. So intensity of electric current that is conventionally being used is either 1.5, 2 or 3 milliampere electric current. Regarding the frequency of sessions, How frequently the sessions to be conducted? Initially, people started with one session per day, 5 working days in a week, over a period of 4 to 6 weeks, constituting around 20 to 30 sessions. Why 5 days a week? That 5 days are working days. So for a convenient reason, people choose 5 sessions in a week. But it's not a contraindication. If you are functioning all the 7 days in a week, you can give sessions consecutively in all the 7 days. Whether we can give more than one session in a given day, definitely we can give more session in a given day. Whether it is going to give additional benefit, ultimate therapeutic outcome will be same, but the response will be a bit faster. Whether it is going to produce more side effect, possible. It can produce more side effects. What type of side effects are likely to come if we give more frequent sessions? More of a local side effects. There may be local irritation, burning sensation. If somebody is a fair skinned person, there will be erythema. So somebody asked whether it is safe for the elderly individuals. It is safe for the elderly individuals, but the thing that need to be considered is in elderly individual, the skins get thickened because of keratinization. During the aging process, there is again more calcification of the dura mater, thickening of the bone. So all those processes, these calcification, age-related changes, all these things, they offer more amount of resistance to passage of electric current. So probably in that scenario, you may consider 2 milliampere or 3 milliampere to overcome this resistance. So those calcification related changes are likely to happen in an aging individual. So suppose you are planning for more frequent sessions. What should be the inter-session interval? How frequently? What should be the gap? Initial research, people suggested that it is better to keep, if you are giving more than one session in a given day, inter-session interval should be kept around 3 to 5 hours. It is more of a safety reason and more of a safety reason. But it is found that if you keep the inter-session interval in an accelerated protocol around 30 minutes to 1 hour, the long-term plasticity, the long-term potentiation will be better. So keeping the sessions more nearer gives a better long-term plasticity. So it is if the patient is tolerating it well, you can keep the inter-session interval 30 minutes to 1 hour. 30 minutes to 1 hour gap. That also gives an additional advantage. Patient will not have to wait for a long time for the another session in that given day. Patient will come, they will have the first session, 30 minutes to 45 minutes interval gap, then second session they can go. A lot of mechanisms has been discussed about how tDCS works. There are some other hidden mechanisms. Why this people tried thinking of the hidden mechanisms? When people treated anxiety disorders using tDCS, they stimulated the left DLPFC and they got the therapeutic benefit by putting the anode. Some of the researchers, what they did the reverse thing. They put the anode over the right DLPFC and they got the benefit also. So stimulating the right DLPFC gives therapeutic benefit, stimulating the left DLPFC gives the therapeutic benefit. People also tried it for treating craving for addiction related research. Some of the Indian studies and Western studies, they report that stimulating the left DLPFC reduces craving. And some of the other studies, they report that stimulating the right DLPFC, it reduces craving. So is it the cortical changes that is responsible for the therapeutic effect, or there's some hidden mechanisms that might be attributing to the therapeutic response? We all know that electric current, irrespective of its strength, they are known to stimulate the conductible tissues like muscles and neurons. So scalp is rich in the nerve endings of the trigeminal nerves. When you put two electrodes through which electric current is either going or coming out, and that is placed for a consecutively for a period of 20 minutes over the scalp, the underlying cortical neurons, which are the free nerve endings of the trigeminal nerves, they are also getting stimulated. The supranuclear connections, particularly locus coeruleus and other related areas, they are also getting stimulated. That's why many people, they report elevation of the mood following trigeminal nerve stimulation because of this release of norepinephrine and related mood elevating neurotransmitters from the locus coeruleus. So this is one mechanism that also explains. And this is how tDCS is also being used in the treatment of trigeminal neuralgia. People, those who are having persistent pain symptoms despite of pharmacological treatment, before nerve block, one may consider trigeminal nerve stimulation by using tDCS. People used to devices like transcutaneous electrical nerve stimulation like TENS. They are using it for management of pain, including trigeminal neuralgia. tDCS can be alternative device that can be used for the management of trigeminal neuralgia. There are evidences not only from animal studies, but from the human studies. Trigeminal nerve stimulation also important in improving the cognition, attention, concentration, arousal. Somebody who is not having ability to focus, not able to concentrate because of anxiety, worry, or some inherent tendency. So this is another answer to those people who are asking before examination, before interview, whether it is going to help. This is one possible explanation. Through trigeminal nerve stimulation, it may help. I'm not encouraging you to practice it, but it's a window to explore whether actually it is helpful or not. So hippocampal neuroplasticity can be mediated through trigeminal nerve stimulation through transcranial direct current stimulation. Now the thing is whether mostly we are using tDCS, or in the clinical research or clinical settings, people use tDCS for as an add-on treatment to the ongoing pharmacotherapy. Now the question is whether the ongoing pharmacotherapy can alter the therapeutic effect of tDCS. Of course, it can affect, because ultimately it is lending, we are dealing with either GABAergic inhibition or glutamatergic inhibition. So GABA and glutamatergic activity is modulated through the mood stabilizers that we are using for bipolar disorder. Valproate, carbamazepine, oxcarbazepine, lamotrigine, all these are affecting this GABA glutamate mediated pathways. So they raise the seizure threshold. So the cortical excitability reduces, so that may affect the therapeutic effect. Benzodiazepines, again, acting through GABA receptors, may reduce the therapeutic efficacy. So it is important to understand, suppose you are using these medications for the treatment of epilepsy. Valproate as a treatment of epilepsy you are giving. It is not important to stop or reduce the dose. Continue on the same dose and deliver the therapy tDCS. Suppose you want to, you are giving it as a mood stabilizer. Valproate as a mood stabilizer, not as an anti-epileptic agent. In this scenario, consider moving to a non-anti-epileptic mood stabilizer, which will have a limited effect on the GABA glutamatergic pathways. Now, tDCS, when it is delivered on the brain, in different brain regions, on different state of the brain, it is having different action. Suppose you are dealing with a healthy cortex. Healthy cortex, here I refers to the brain that is structurally normal and functionally in the molecular level, because we all know that all the psychiatric conditions, the functional level, there are some amount of alteration either in the neurotransmitter level or in the receptor level or in the intracellular signaling pathway level, somewhere it is there. So we cannot say that the brain is completely healthy in an individual which is not having any neurological illness but having a psychiatric illness, exclusively depressive episode. There are some changes. So, but practical for this understanding, we consider that to be a structurally normal brain. In a structurally normal brain, when you deliver electric current, cathodal stimulation will produce stimulation, anodal modulation will produce an inhibitory effect. But suppose somebody is having a traumatic brain injury, there is an acute injury, Following acute traumatic brain injury, there is glutamatergic hyperactivity. So in that scenario, whether you put a cathode, it will produce stimulation. Whether you put a anode, that will produce stimulation. So ultimate effect is a stimulatory effect. As the condition progresses, in the subacute phase, the glutamatergic hyperactivity is replaced by GABAergic activity. Again, in that phase, if you plan for neuromodulation, you are not going to get the desired effect. So finally, maybe over several months, the brain plasticity and brain structural integrity, the normal healing pathway, try to restore all those things. Nearly body tries to make the functionality nearly normal. In those scenarios, one may try with tDCS for neuromodulation if there is a persistent cognitive symptom, persistent mood symptom, persistent behavioral symptoms. So the point is, in the acute phase, response is unpredictable, so it is better to avoid. Subacute phase, again, response is unpredictable, better to avoid, unless otherwise you have an investigational modality that gives you a real-time feedback what is happening inside the brain. There are some practice guidelines in India as well as abroad, which gives a clinical framework how to use tDCS. You can refer to these guidelines. It has been given to you, and many of you as a resource material as well. Now we'll talk about the important protocols that are used for various psychiatric conditions as well as neurological conditions. Neurocognitive disorder is one of the commonest conditions where people use a lot of pharmacotherapy with limited improvement, but finally we focus on home-based care, how to do the rehabilitation, how to provide a supportive care. But neuromodulation like tDCS can be an opportunity where we can enhance the cognitive abilities. Like dorsolateral prefrontal cortex can be stimulated by using the placement of anode, which produces some amount of cognitive benefits, particularly in the domains of attention, concentration, processing speed, the working memory, the visual, verbal fluency, and some other components of executive function. Mostly people use 2 milliampere electric current around 15 to 30 minutes, one session per day, around 6 to 10 sessions. Here I'll say that the number of sessions, how many number of sessions to be given to see a noticeable benefit? Because of logistic issues, because of convenient issues, because of transport related issues, many people, they restricted the number of sessions. Mostly the trials, they restricted the number of sessions to 6 to 10 sessions. However, it is safely tolerated, as it has been reported by several case reports and studies, for a longer sessions. The more longer the session, that is more number of sessions you give for a longer period of time, the expected benefit is better. Depression is one of the commonest psychiatric indication where tDCS is being used. Why people target left DLPFC? It is not having a direct relation with the management of depression, but it is having an indirect association. There is an interesting association between left dorsolateral prefrontal cortex and anterocingulate cortex, particularly the subgenual part of the anterocingulate cortex. The part of anterocingulate cortex that is below the genu of corpus callosum, that is basically responsible for the processing of the emotions. And their cognitive processing is happening in the DLPFC related areas. So what happens in depression, in the dominant hemisphere, in the left hemisphere, there is a hyperactivity of the subgenual anterocingulate cortex that is responsible for the pathogenesis of depressive symptoms. And that hyperactivity, that area, we cannot target either with TMS or through tDCS, because that is deeply located somewhere in a hidden location medially. So we need to choose an area that is functionally connected to this area. So dorsolateral prefrontal cortex, which is easily amenable for neuromodulation, is functionally connected to subgenual anterocingulate cortex. And the functional connectivity is more of an anti-relation. Hyperactivity of subgenual anterocingulate cortex is leading to underactivity of left dorsolateral prefrontal cortex. So they have an inverse association. Suppose you stimulate the left dorsolateral prefrontal cortex, that becomes hyperactive or normoactive, and that will suppress the activity of subgenual anterocingulate cortex. This is how actually it works. So reverse happens with the opposite hemisphere. There is hyperactivity of right DLPFC and underactivity of right subgenual anterocingulate cortex. Suppose what one good thing is you can target both the cortical areas through the conventional tDCS, putting the anode over the left DLPFC and cathode over the right DLPFC. Again, parameters 1 to 2 milliampere electric current, 20 to 30 minutes, 1 session per day, up to 20 sessions, but you can go beyond that. Even you can consider for the maintenance sessions. Coming to schizophrenia is again three important constructs of symptoms that are being targeted in schizophrenia. One is auditory hallucination, which is a positive symptom. One is a negative symptoms, social withdrawal, apathy. And third domain is cognitive symptoms. In long run, there will be cognitive symptoms. Cognitive, negative symptoms, they are related with left dorsolateral prefrontal cortex integrity, and the auditory hallucination, they are related to left temporoparietal junction hyperactivity. So there is a group of neurons in the temporoparietal junction. There is excessive corollary discharge of the neurons, which is responsible for auditory hallucination. So can we do these two activities simultaneously? Yes, it is possible with conventional tDCS. You can put the cathode over the left temporoparietal junction, and you can put the anode over the left DLPFC. Simultaneously, you can inhibit the temporoparietal junction and stimulate the dorsolateral prefrontal cortex, which is going to give you all the desired benefits. It is not essential that every patient will respond, but this is how the theoretical model, theoretical recommended medicine in schizophrenia, it is being done. Patients with schizophrenia, they don't respond too early in the course of treatment. It should not discourage you from discontinuing tDCS, considering it to be, it's not working in this patient. Many patients with schizophrenia, many patients with OCD, they respond late in the course of treatment. Maybe after 15 sessions, maybe after 20 sessions, they start responding. So if it is convenient for the patient, if it is well tolerated by the patient, you can continue before discarding tDCS. Substance use disorder is another condition which refers to variety of substances starting from tobacco, alcohol, cannabis, opioid, cocaine, and other newer psychoactive substances. Among the substances, tobacco and alcohol, these are the two conditions where tDCS is being extensively researched. Another study is with reference to opioid and cocaine, but the number of studies are quite less and mostly limited to very small sample size, less than 20 sample size. So the conflicting thing that I was talking earlier, you started targeting right DLPFC, started targeting left DLPFC by putting a node using the same protocol, and they got benefit in some of the patients. So evidences are mostly in favor of anodal tDCS over left DLPFC, which produces some amount of cognitive enhancement or cognitive distortion correction in patients with substance use disorder. It reduces the anxiety level. It also reduces the craving, increases the abstinence duration. So it is doable. Obsessive compulsive disorder is another condition where tDCS is extensively studied. And the number of brain areas that are being evaluated in OCD is maximum. In all the other conditions, people tried with DLPFC or some of the areas, temporoparietal junction, but OCD's area just started trying left dorsolateral prefrontal cortex, right DLPFC, cerebellum, supplementary motor area, pre-supplementary motor area. So variety of areas has been tried. So if you refer to the corticostriato-thalamocortical loop, we cannot target striatum and thalamus directly through these superficial neuromodulation techniques like TMS and tDCS, because finally these areas we cannot modulate. So for that we require either we have to go for deep TMS, or we need to have modification of the coil like double cone kind of coil, or we have to go for deep brain stimulation, particularly targeting the ventral aspect of antral limb of internal capsule, vallic. So actually that benefit is accidental finding. People tried targeting Parkinson disease for the vallic, and they also found some improvement in the OC related symptoms. They thought that striatum is involved with Parkinson disease, striatum is involved with OCD. There might be some common etiopathogenesis where we can use DBS and get the benefit. So this is how it started. That is invasive neuromodulation. Network meta-analysis suggests that that is among the neuromodulation, that is the best one. But we cannot recommend it for all the patients, or that facility is not everywhere available. Non-invasive neuromodulation can be alternative. I will try to finish in next 10 to 15 minutes. The current strength is 2 to 3 milliampere, 20 to 30 minutes protocols are given. Supplementary motor, in this context, just I want to highlight that supplementary motor area is functionally connected to striatum. Striatal hyperactivity is directly correlated with hyperactivity of the supplementary motor area. We cannot modulate the activity of striatum directly, but we can modulate the activity of supplementary motor area. So if you inhibit the supplementary motor area, striatal hyperactivity can be suppressed through indirect mechanism. So this is the reason why supplementary motor area was targeted in OCD. So hyperactivity of the supplementary motor area in OCD is a very complex thing. People tried using, they either inhibited the supplementary motor area. Many people, they also stimulated the supplementary motor area and they got the benefit. But consistent finding is hyperactivity of supplementary motor area. So the hypothesis behind hyperactivity of supplementary motor area in OCD, it can be a cause of OCD. Hyperactivity of the brain area leading to development of OCD symptoms and neurobiology of OCD. Hyperactivity of the striatum, second hypothesis is striatal hyperactivity can be a consequence of OCD. OCD happened, some brain changes happened, some abnormal aberrant functional connectivity happened, ultimately leading to hyperactivity of the striatum and supplementary motor area. So this is second hypothesis. Third is a compensatory mechanism. Because of OCD, some brain changes happen. Because of that, some deficit happened in the brain. And to overcome that deficit, supplementary motor area became hyperactive. So it's a compensatory mechanism. If it is a cause of OCD, it's very straightforward. It is causing OCD, inhibit it, it will improve the symptoms of OCD. But it is not always the same. We don't know in a given individual with OCD whether the hyperactivity is the cause or the consequence or the compensation through a cross-sectional study. For that, we need to have a longitudinal study or a study where you induce hyperactivity and look for the OC symptoms, which is not ethically acceptable. Maybe you can do it in the experimental animals. So this is the area where further studies are going on to explore. Can we predict neuromodulation on the basis of neuroimaging hyperactivity changes? So studies are going on. Autism is another condition where target symptoms were executive function, social cognition, and behavioral symptoms using 1 to 2 milliampere electric current. Because autism patients, when there is a hypersensitivity to stimulus, may be there. Some of them are hypersensitive, some are hyposensitive. If the individual is hypersensitive, even with a very low frequency intensity, they may be sensitive to that, they may be reactive to that. So one may try with a low intensity electric current like 1 milliampere. Attention deficit hyperactivity disorder. Again, DLPFC is targeted anodal stimulation. Targeting left DLPFC produces some improvement in the cognitive symptoms, particularly attention, concentration, and the executive functions. Tourette syndrome, again, for the tic, one can target the pre-supplementary motor area and left motor area with cathode, which will suppress the cortical activity and can suppress the tics. You can see there are places where the electrode is placed over the arm, deltoid, mastoid, supraorbital, these areas. These are actually neutral sites. Placing electrode there will not produce any neuromodulation over that area. Suppose you want to target a single cortical area for neuromodulation, you can put the desired electrode over that area. It may be a cathode, it may be a anode. The other electrode can be put over a neutral site. Suppose you are targeting for dual cortical modulation, like in depression, I will be interested in doing stimulation of the left DLPFC and inhibition of the right DLPFC. I can use both of my electrodes, putting one anode over the left DLPFC, cathode over the right DLPFC. But for anxiety disorder, I may be interested in reducing the hyperarousal symptoms of the left DLPFC by putting the cathode, or by cognitive errors by putting the in the left DLPFC by putting the left DLPFC anode there, and the neutral electrode I want to put it in a site, not in a cortical site. I can put over the deltoid, over the mastoid, over the arm, or over the right supraorbital ridge. Beyond psychiatry, it can be used in traumatic brain injury. Particularly, people used it in mostly in the chronic traumatic brain injury patients with a mild traumatic brain injury. A lot of variations in the target sites, because you cannot predict which area of the brain is going to be affected. Traumatic brain injury can affect any of the areas. So where to put the electrode, that if it is a superficially accessible area, if the lesion was there in those areas, you can target those areas. Otherwise, if it's a deep-seated area, maybe tDCS may not be the appropriate choice if you are not getting a functionally connected area to that area. Challenges are mostly related to finding optimal protocol. So placement of tDCS, anodal tDCS causes improvement of the motor skills, language processing, memory consolidation, whereas cathodal placement is beneficial in suppressing the hyperarousal. Mostly 1 to 2 milliampere electric current, 20 minutes protocol, 10 to 20 sessions are given. tDCS can also be used in the management of Parkinson disease. This is one of the systematic review meta-analysis that I'm referring to. They used 21 studies that use tDCS as a modality of treatment for Parkinson disease, including more than 730 patients. So they found that tDCS causes improvement in the cognitive performance. Particularly patients with Parkinson disease, they have either cognitive symptoms due to anticholinergic use, they have cognitive symptoms due to ongoing neurodegenerative process in the other brain areas, or dementia associated with Parkinson disease. So cognitive functioning is grossly affected in majority of the patients with Parkinson disease, at least in the advanced stages. In those scenarios, tDCS is beneficial. But regarding the motor symptoms, which is actually the core symptom of Parkinson disease, which is actually bothering the patient and the family member the most, the evidences are insufficient. TMS related evidences are more favoring Parkinson disease, but tDCS related research, mostly it is limited by small sample size, mostly it is understudied. Another systematic review meta-analysis that evaluated two important domains, motor domain and cognitive domain. Lot of heterogeneity is there in the study. They found no improvement, no difference in the motor function, gait, and cognition when they did the intergroup comparison of active and SAM. But they did some advanced statistical analysis, meta-regression analysis. They found small positive effect in Parkinson disease in those individuals who are young individuals and having milder symptoms. In pain-related conditions associated with Parkinson disease, people used tDCS, and significant improvement happened after tDCS targeting the primary motor cortex. So Dr. Mohita has already highlighted that fibromyalgia, pain-related conditions where tDCS is having a better efficacy level B. So it is in the same paradigm. tDCS is also being used in some of the other meta-analysis. They report that there is improvement in the gait and balance in individuals with Parkinson disease. So there are evidences, there is no improvement. SAM and tDCS, active tDCS, there are evidences of mild improvement. There are evidences of better improvement with active tDCS. So there are a spectrum of evidences Now, all these studies, they conclude that a lot of heterogeneity is there and small sample size is there. What we require is a larger sample size to have a more conclusive evidence. tDCS, when combined with some physiotherapy measures like improving mobility, stability, other management exercises, so it is as a add-on management, combining tDCS with all these physiotherapy measures, it helps in improvement in the motor functions. Then these exercises alone. So probably when you are combining the physical exercises, so it is not a resting state of the brain. Motor activity is happening, so some amount of cortical areas are getting stimulated and you are modulating the activity of that brain areas through tDCS. So probably now the thing is, can tDCS combining in an activated brain gives a better result? That activation can be achieved through either priming or through some physical exercises or motor activities. In the management of epilepsy, tDCS has been used. The findings suggest that tDCS significantly reduces the seizure frequency, particularly those seizure epilepsy patients, those where we can easily identify the focus of epilepsy, epileptic focus. A few minutes back, Dr. Sharma was also saying that it is important to identify that circuit that is being involved in epilepsy. If you can correctly identify that circuit, then you can probably effectively modulate it and control seizure. Not every individuals where you will get that identifiable set. Majority of the patients with epilepsy may have a normal EEG finding, may have a normal neuroimaging finding, but still epilepsy process is going on. In those scenarios, targeting the appropriate focus becomes difficult. But having epileptic focus, either pathological lesion or traumatic brain injury or tuberculoma, or those scenarios, it's quite easy. So cathodal tDCS is mostly useful in patients with refractory epilepsy because ultimately we need to inhibit the hyperactive epileptic focus by cathode. So putting cathode over the epileptic focus and putting the anode over a neutral site, that is the usual way of dealing with epilepsy. In our center, we tried using tDCS in a series of patients with refractory epilepsy. So in those scenarios, patients were around 6 to 8 anti-epileptic medications at the time of initiation of tDCS. 2 or 3 patients, they were also undergone epilepsy surgery. And despite of that, the epilepsy process was going on. When we started tDCS as a add-on treatment, the frequency of epilepsy episodes in the day and the severity of the episodes and the duration of seizure-free interval, all those things has increased. However, it is limited to, our experience is limited to some case, 6 to 7 cases. We need to have more number of similar scenarios to substantiate this evidence. In the management of pain, tDCS is also being used. In the pain management, there are two important areas. One is a cognitive component of pain. So somebody who is having chronic pain, they have some negative self-appraisal about the health, about the person, about the illness. They have a lot of cognitive errors. They have comorbid anxiety, depressive symptoms because of the long-standing disabling condition. So, and those conditions further aggravate the persistence of the pain. Second is area that is directly related to pain, that is sensory cortex, thalamus, and sensory motor integration. So we can target either DLPFC or the primary motor cortex. Evidences support that stimulating the primary motor cortex can cause sensory motor integration. Through sensory motor integration, it can cause neuromodulation. It can inhibit the pain perception, pain severity. Even DLPFC stimulation will also produce similar kind of effects. So in chronic low back pain, people tried using tDCS as a modality of treatment, and they found that there is significant improvement, a reduction in the pain symptoms in comparison to the SAM counterpart. Patients with fibromyalgia, they also reported improvement in the pain symptoms. So again, target is DLPFC in primary motor cortex. tDCS was used in patients with stroke. Those who are having a lot of motor deficit following stroke, they used tDCS as a add-on treatment to constraint induced movement therapy in post-stroke patient, and they found that it is safe, well tolerated, and there is some improvement in the motor symptoms. But mostly the duration of intervention that is required for stroke patient is longer. In our setup, we had given two patients with stroke with tDCS. One patient was referred from Dehradun, where the patient is having significant motor deficits because she had multiple episodes of stroke. So both right side and left side hemispheres, both sides are affected. So we started with the principle, the deficits are huge. The areas of brain affected are very significant areas are affected. Now, wherever you put the electrode, some amount of benefit is going to happen because the underlying cortex is dysfunctional. The second thing, the negative part is wherever you put the electrode, some amount of deficit will remain because large area of the brain is affected, bilateral it is affected. The patient was wheelchair bound. After 40 sessions of tDCS, patient was able to walk with support. So, and it was an add-on to the ongoing physiotherapy. So, it can be tried. So, stroke recovery, it facilitates that process. So, it is feasible and safe. Particularly in the treatment of aphasia, it can also be as a add-on treatment. In aphasia, what happens when the dominant hemisphere Broca's area is affected, the contralateral homologous area becomes hyperactive because of the cortical reorganization to overtake the activity of the Broca's area. So that hyperactivity interferes in the recovery of the Broca's area. So one can stimulate the Broca's area by putting the anode there and inhibit the opposite side, right side Broca's homologous area by putting the cathode there, so you can get the benefit. So in different phases of aphasia, it has been tried. There is some improvement in social participation related things in terms of neuromodulation. So in the systematic review and network meta-analysis of randomized controlled trials that used tDCS for the management of aphasia, they found that they tried to rank what type of neuromodulation tDCS is more effective. If you are looking for functional communication, probably anodal stimulation is more beneficial. If you are looking for naming the nouns, cathodal stimulation is bit superior. In terms of performance of the naming of the verbs, then cathodal stimulation probably better than anodal. Marginal, they are different, 0.63 and 0.64. If you are looking for safety, of course, it is SAM. It is not having any effect, so it is not going to produce. There are side effects as well. Anodal tDCS produces benefit in patients of migraine, particularly targeting the primary motor cortex. So it reduces the number of attacks. Pain intensity is also being reduced. Attack duration is being reduced. The need for analgesics has been also reduced. So tDCS can be a modality which can be used in the management of migraine, particularly refractory migraine. Fibromyalgia, migraine, neuropathic pain, spinal cord related injury related pain, stroke related conditions, they respond to tDCS. There are some practical components. We'll be talking about it during the hands-on training in the afternoon session. Safety wise, if you compare, tDCS is more safer than TMS and ECT. But if you talk about efficacy, particularly in the context of depression, ECT is most efficacious than TMS. tDCS is having relatively lesser efficacy than TMS and ECT. There was a network meta-analysis evaluating different neuromodulation techniques in the acute management of depressive episode. they found out that ECT is most efficacious, but tDCS is though relatively less efficacious, but it becomes more acceptable. We did some of the randomized clinical trials several years back. Dr. Bubbly did it, tDCS as an early augmentation in the treatment of depression, which is published in Asian Journal of Psychiatry. Dr. Aditya did it for adolescent OCD patients as an early augmentation strategy. And Dr. Arundhati used tDCS as an anti-craving measure in patients with alcohol use disorder. Dr. Lokesh is present here today. He used it for the management of OCD in adult patients. Dr. Soumya, she is also senior resident in our department. She used it in the management of adolescent depression. All these studies where we use tDCS as an early augmentation strategy. And the finding is that there is a beneficial effect of tDCS as an add-on treatment comparison to the SAM counterpart. If you add it early in the course of treatment, the patient can resume the functioning early and can have a early reduction of the symptoms. So there are some techniques that we are going to discuss in the afternoon. Here I will stop. Thank you so much.
Thank you, Dr. Sujit. It was very comprehensive as well as exhaustive session. I hope that lot of your questions or queries are already answered. The session is open for questions now, please.
Sir, thank you first of all for wonderfully explaining all the things in simple words. In the start of your presentation, you compared tDCS with ECT just for the sake of our understanding, which brought some curiosity to my mind. My first question is, do we need titration in the dosing schedule with tDCS as we need in ECT?
No, we don't have that titration option in tDCS. Usually you start with a defined protocol, you continue with that same protocol over a period of time. If you want to do some modification in the protocol, like if you don't get any response at least after 10 to 20 sessions, you want to do some modification in the protocol, you can change the site, you can do priming. Either you can do priming by tDCS or you can do priming with TMS, but there is no possibility of titrating. Titration possibility comes when there is patient is reporting benefit, but there is side effect. There is pricking sensation, there is burning sensation, formation of scald. In those conditions, you can titrate the dose of electric current in terms of reducing the duration, in terms of reducing the intensity of electric current. So those titration you can do if there is a perceived benefit. At the same time, there is some side effect that is being reported.
So in continuation of that question, when we use tDCS as an augmenting agent or with other psychotropic drugs, do we need any change in the dosing schedule? Or?
No, you can continue with the same dose of the psychotropic medication. Dosing modification is required for those medications that alter the cortical excitability. That I have already mentioned, that benzodiazepine or mood stabilizer with anti-epileptic properties that are being used, this can be reduced to a minimum possible dose. But there are many research where people used tDCS as an add-on treatment with concomitant mood stabilizers and concomitant benzodiazepines, but it is better to keep the dose as minimum possible.
So we can face any cognitive side effect when we use?
In those scenarios, because you are not increasing the dose of electric current, the dose is remaining same. So cognitive side effect will not be there, but the therapeutic efficacy will be compromised.
And sir, on the other line, in the start of the presentation, you said that theoretically it can help with anxiety issues, performance anxiety issues. So does it can have any rebound phenomena? It can be with time, but
Yeah,
carry it remote?
because the effect of tDCS is short lasting. So once the effect will go, the phenomenon, the underlying things will come out again.
Regarding the dose modification, just wanted to add one more thing. Because in ECG, there is an intervening phenomena from stimulation to response, that is seizure, which you can observe and modulate that what is the minimum effective period of seizure that is required, and if the seizure is prolonged. So those are the intervening phenomena. In the neural brain stimulation, we are measuring the response by the clinical pointers, which are not often quickly and easily measurable. That is why there is the possibility of dose modification in terms of observing efficacy.
Sir, actually, I wanted to ask a question. Sir, if we are doing a study, say on anxiety disorder and comparing the efficacy of tDCS in anxiety disorder, and we have to give benzodiazepines, then in that case, SOS benzodiazepines would be preferred, or a fixed minimum dose benzodiazepine and a short-acting benzodiazepine, or a longer one would be to minimize the harm on tDCS.
Okay. SOS benzodiazepine will be more harmful. You say that suppose 3 days you have taken it, 2 days you have not taken it. So the cortical excitability will be more of a fluctuating kind of thing. Suppose somebody is taking a benzodiazepine at a constantly lower dose, that is more acceptable, that most studies allow. Suppose you use a long-acting benzodiazepine, then it will be having a round-the-clock effect. But if you are using a short-acting benzodiazepine, then you need to think of the session when you are giving that session. How many hours after the benzodiazepine use? It's very difficult to monitor that patient will take benzodiazepine in the morning, and exactly at a particular time in the afternoon or in the evening, you will deliver the therapy. Patient may take the medication bit early, may come bit early, therapy may become late. So again, it is affecting the cortical excitability. So a uniform effect is not expected if somebody is taking short-acting benzodiazepine or patient is taking SOS benzodiazepine. This is for research purpose. For clinical purpose, it can be done. But for a research purpose, if you want to look for a particular electrophysiological finding or cortical activity through serial monitoring, so you should follow that protocol uniformly. If the patient is on benzodiazepine, they should be in a given range of dose throughout the study period. That flexibility is there, but you need to fix it a priori so that the findings can be evaluated in this line.
Thank you so much, sir, for your wonderful session. My question is a little more practical. If I think of introducing this technique to my department or in clinical practice, is there any regulatory protocol that we are supposed to follow in order to introduce this?
If you want to do it, procure it for your department, particularly in India, procuring a device in the institution requires some of the things you need to see. One is whether that device is a mandatory requirement for running a undergraduate or postgraduate curriculum. Till now, tDCS is not a mandatory requirement for undergraduate curriculum. tDCS can be as an optional requirement. TMS tDCS are optional requirement. It would be better if you can have those facilities in your institute. Suppose your department is having a postgraduate course, you can have it for the postgraduate students learning. Third thing is regarding whether the device is approved by Indian regulatory authorities or not. Indian regulatory authorities like CDSCO has approved tDCS in the management of psychiatric and neurological conditions. So that approval is there. Then from the institution point of view, the thing for which the device is being indicated, how many number of patients you are getting in your institution, whether you are able to utilize that facility So you need to convince your administration that this is the patient footfall, this is the need, and this is the requirement. So accordingly, you can pursue for that.
Sir, myself, Dr. Joshi, Assistant Professor, TS Medical College. So I want to ask to Joshi. The first question is that whether you have seen any case where the patient was stable on a certain dose of medication, like we say in CD, but due to adverse effect, he don't want to continue that much amount of drugs, or due to he want to use the drug and they shifted it to tDCS, and then you will be able to reduce the dose further augmented later on, and the effect persisted. The patient will make stable and the dose also gets reduced. Have you seen any cases like this?
Yeah. We have used tDCS as a add-on. You can please sit. We can use tDCS as a add-on treatment. There are patients who are stable on treatment, but over a period of time, they discontinued the medication or they reduced the dose of their own, and some of the symptoms they emerged. They reported that medications are costly, and fortunately, we are offering tDCS free of cost at our institute. So for the acute management of the symptoms, we enrolled few of these patients for add-on tDCS with a relatively lower dose of serotonergic medication, and they were maintained well. And a few of these patients, they are on maintenance tDCS. Few are maintenance tDCS, few are on maintenance TMS. Regarding the second question was related to.
The second question I'm going to ask. The second question is that, like you are saying, you are saying that in last year you have approved it for home use of tDCS. Do you see in future that in private practice, the doctors can be, the scientists can be able to provide tDCS device to the patient?
Of course.
Like, and
After this FDA approval, there are 2 Indian companies and a few more companies, they are coming with devices. They are remotely operated. To the best of my knowledge, 2 Indian companies, they introduced tDCS machines, which are available in a affordable price. They can be remotely operated. They are basically meant for the patient can come and they take the machine on rent, and they can do the neuromodulation at home as decided by the clinician. And additionally, that device gives a benefit of simultaneous recording of the EEG during the session. So that type of devices are coming and in an affordable price. So likely that psychiatrists will start practicing using it in the coming days.
सर मैं पूछना चाहता हूँ कि साइकोफार्माकोलॉजी और साइकोलॉजी के कॉम्बिनेशन का जो रिजल्ट होता है वो सर टीडीसीएस और फार्माकोलॉजी के रिजल्ट से कुछ ऐसी थीसिस वगैरह है, कुछ ऐसी स्टडीज है कि जो कौन सा बेटर है?
It's a good idea for the new residents to opt for a thesis. So there are studies that compared tDCS versus pharmacotherapy, tDCS add-on to pharmacotherapy with pharmacotherapy alone. Limited number of studies are there with combining tDCS with psychotherapy, combining tDCS with pharmacotherapy, and looking for the outcomes. These are the areas where we can integrate multiple modalities of treatment together. In fact, I'll say that we used tDCS as a part of multimodal treatment. In some of the patients, we published that as case reports, where we suppose a patient is having OCD. We tried with tDCS, we tried with exposure response prevention, we tried with pharmacotherapy. All the 3 things going concomitantly in a hospitalized patient, and those patients they otherwise would not have responded to pharmacotherapy alone or past failed trials. They reported significant improvement in their symptoms. So multimodal treatment, more of a tailor-made customized treatment for the patient, will be definitely beneficial.
Thank you for the excellent presentation, sir. My question is, like Dr. Adarsh mentioned, we cannot monitor the process while it is being given, like ECG. So, can we have, are there a number of sessions we have to wait before declaring whether it is effective or not effective? Or do we continue through the whole protocol?
There are two types of devices. One type of device is mostly for delivering the therapy, clinical purpose. There are some devices, they are basically for research purposes. Those devices have additional features like real time during which you deliver the therapy, whether there is any brain changes are happening or not. At the same time, you are monitoring the EEG. Even you are quantifying the EEG, QEEG, you can monitor during delivering the therapy. So you can see the change in the brain across the sections, across the sessions. In the first session, the brain change was something. After 10 sessions, the change was something different. So those things will give you an idea whether actually tDCS is capable enough in bringing some electrophysiological changes in the brain or not. This is one thing. Second, those electrophysiological changes that are happening in the brain cannot be directly translated to clinical improvement. There are many studies, they reported that after sessions of tDCS, EEG changes happened in the brain from the baseline, but there is no clinical improvement. So something else is missing. We need to do further research to understand how and why brain is behaving in a very different way. Despite of change in the brain, functions are not improving.
But so
far, we need to.
There are no side effects. It's better to
continue the sessions for at least 10 to 20 sessions before discarding it.
One more question, you mentioned about accelerated protocols in tDCS is also used.
Yeah, accelerated protocol in TMS can be used, in tDCS can be used. In fact, there was a recently registered trial where they were using tDCS as a accelerated protocol 5 sessions in a day in the management of depression. 5 sessions in a day versus 1 session in a day. So you deliver 10 sessions over a period of 2 days. In other scenario, you deliver 10 sessions over a period of 2 weeks. Now you are comparing the efficacy and safety. Accelerated in terms of number of sessions you deliver in a day. If you give 1 session in a day, it's a conventional protocol. If you go for more than 2 sessions in a 2 or more than 2 sessions in a day, it is accelerated protocol. No. In theta burst stimulation also, accelerated refers to more number of theta. You have given 1 session, then followed by another session. So number of sessions in a given day is accelerated protocol. Extended protocol refers to when you go beyond the conventional protocol. Suppose majority of the protocol they recommend for 20 sessions, but you are giving 60 sessions. So you are going beyond the recommended duration of the number of sessions. So it is extended protocol.
Like MSA right now does not when we talk about tDCS and all. So in pediatric population, we could have.
FDA recommends for adult population. Whatever the existing RCTs or systematic reviews or meta-analysis are there, they absolutely establish that it is safe in pediatric population. One thing that is bothering is pediatric population, they are more likely to experience the local side effects. Local side effect like because the skin is soft and fragile, so we'll get burning sensation, pricking sensation, this type of things may happen in the small kids.
What we plan research, do we have to?
Adolescent population you can give, but for the very young children, one need to take due approval from the concerned regulatory authorities for use it.
Sir, I want to know from your experience on tDCS in patient with schizophrenia. Is there a subgroup of schizophrenia patient like those who have neuropsychiatric symptoms and those who have different symptoms? What is your experience?
Regarding schizophrenia, basically, if I talk about my own experience, we use auditory hallucination is the commonest target of management of schizophrenia. So there are options where you can use for cognitive stimulation where DLPFC can be targeted, cerebellum can be targeted. If you can target for negative symptoms, you can target the left DLPFC. Mostly we used high definition tDCS for targeting the left temporoparietal junction with cathode at the center and anode in a ring electrode. Or we, in the conventional electrode placement, we put the cathode over the left DLPFC, cathode over the left temporoparietal junction and anode over the left DLPFC.
So I hope there are no more questions. So thank you, Dr. Sujit, for very interesting session. So
here we close the online sessions. Now we'll be moving to the hands-on training after the post-lunch session. So I just request all the participants to give their feedback. We'll be circulating the feedback form shortly after concluding the program, today's program. We have provided our email address. If anybody is willing to get any resource material, we are happy to share it. From my side, I personally want to thank Professor Rainer for taking time on this Sunday, getting up early in the morning and joining the workshop. Thank you so much, Professor Rainer.
Okay, thanks from our side, and I think it was a marvelous talk, and yeah, we're so proud to support you and in your endeavor, and I also hope that your